I'd like to spend a few minutes now talking to you about the Plymouth clinical strategy for the next 10 years, and particularly around our understanding of our population's health, understanding the needs of our population so that when we design new services, they're appropriate for the needs of our population. So many of you will have seen this slide before, and this is looking at how we're going to deliver our clinical services going forward. That includes our role as a regional hospital. It's our role as an acute hospital for our local population. It's our role in the community, integrating with primary care and other health givers in the community. And it's how we deliver care in patients' home, looking at new ways of working, such as video consultation and the use of technology. Beneath that are the pillars of digital system integration, estates and facilities and workforce that we need to deliver services to our patients. And underpinning that is our understanding of population health, identifying individuals' needs and personalising care to meet those needs. And that's what I'd like to talk about you today. In particular, our understanding of the deprivation of our population, the impact of our location as a coastal community and that impact on our both physical and mental health, the age demographic and the changing age demographic for our population, and what we're planning on doing with this information going forwards. So there's a national agenda coming out of COVID to level up, using Boris Johnson's phrase. And that means that we're looking at the core 20% of the population who are living in most deprivation, and ensuring that those people are not disadvantaged when trying to seek healthcare. Looking at other groups of patients who are underrepresented when it comes to accessing healthcare, and then some other priorities around maternity services, severe mental illness, respiratory disease, early cancer diagnosis, and hypertension. When you look particularly at that core 20 of deprivation, there's a scale called the Index of Multiple Deprivation, which gives you a score from 1, most deprived, to 10, least deprived. That then is then further divided into quintiles. So the bottom 20%, that 1 and 2 part of the population, are the core 20 of most deprived. And when you look at this map of the Plymouth population, the population that University Hospitals Plymouth covers, 25% of our population lives in that bottom quintile of deprivation. They're in the core 20 of deprived patients. That means that for our population in Devon and Cornwall as a whole, half of the deprived people who live in Devon and Cornwall live within the catchment area of UHP, and many of those people live in central Plymouth. If you compare that to rural Devon and Exeter, 2% of the population in the rural Devon and Exeter catchment area live in that bottom quintile of deprivation. What's more striking is that this IMD, this Index of Multiple Deprivation, is made up of 7 scores. And what's striking is how poor the health score is for the patients who live in Plymouth. So Plymouth is scoring 3 out of 10 overall on the health score, compared to 6 for West Devon, 5 for Cornwall, and 5.5 for Exeter. So we're living with a patient population who are very unhealthy. If you break this down into neighbourhoods, the LSOA in technical terms, half of Plymouth's population are living in the first and second most deprived deciles when it comes to health. And when you look at the map on the left-hand side of this slide, you can very much see that this poor health is concentrated in areas around Plymouth city centre and around the waterfront, but also out into the Ernesettle and Crown Hill, Buds Head areas. What does this mean from our patient's health point of view? It's really clear that avoidable mortality is much higher in deprived groups. So the chart here shows the 10 levels of deprivation, these 10 IMDs, and it's the deaths per 100,000 population of which are avoidable. You can see are significantly higher in groups 1 and 2, 25% of our population, compared to those who are living in groups 9 and 10. This was a finding of the Marmot Review, which came out in 2010, looking at called Fair Society and Healthy Lives, and was repeated in 2021. And it's really clear that the lower your position in society, the worse your health is. And those inequalities seem to have grown between 2010 and 2021. You can look at the rollout of the COVID vaccine in the Plymouth area at the start of this year. So we thought made things easy for our patients. We thought that we had made access to the COVID vaccine accessible by the work that was done at Home Park, extended opening hours. And yet on the left-hand side here, you can see that the orange bars are the Plymouth PCNs, the Plymouth GP practices, and the cluster of bars at the left-hand side, the worst take-up of boosters for COVID in Devon were in the most deprived city centre PCNs, whereas at the right-hand side you have West Devon, which covers Tavistock, and Mewstone, which goes out into the South Hams, where the take-up of COVID boosters was the same as the rest of Devon. All this adds up to our patient population having a shorter life and a shorter life in healthy life years. So you can see the healthy life years for Plymouth on the left-hand side sit at 61.8, and that's 6 fewer healthy years than the rest of Devon. And in particular, it means that when people in IMDs 1 and 2 hit their mid-50s, they start to develop symptomatic long-term conditions, which are then going to impact their healthy life for the rest of their days. The second part of our complexity from a population health point of view is our place as a coastal community. So Chris Whitty, the Chief Medical Officer, writes an annual report, and in 2021, despite the fact that we were going through a COVID pandemic, he decided to do his on health in coastal communities. And the summary was that coastal communities have a higher burden of disease against physical and mental health conditions, particularly driven by their age structure and a concentration of deprivation. Even after accounting for these, there's an excess of poor health in coastal communities, particularly mental health. The graph on the right-hand side is a national graph of presentations to the emergency department with acute mental health problems. And you will see that Plymouth sits well to the right of the graph, so that more than 1 in 20 patients presenting to our emergency department has mental health as a significant part of their attendance. This whole deprivation means that we end up with more emergency department attendances per 1,000 population in our deciles 1 to 3. And those people are less likely to be admitted. They're turning up with conditions to the emergency department, which don't lead to a hospital admission. In outpatients, we know that people who live in deprivation are less likely to be referred in as a routine outpatient. But what's quite striking is that the proportion of DNAs for these people living with more deprivation are considerably higher than they are for those living in relative wealth. The third point I'd like to point out is the change in our age profile. So we already know that we have an older than average population, but the two graphs on the left-hand side of this chart are the change in the age bands from 2011 to 2021. And in fact, West Devon, so Tavistock and the South Hams, was highlighted nationally as an area with the highest growth in the over 65 population. This is likely to continue. So despite the fact that we've seen this growth over the last 10 years, we expect to see a further growth of 20% in the number of patients over the age of 65, amount of population over 65 in our catchment area in the next 10 years. And at the same time, we lose working age population. So we lose the people who are going to care for us, and we gain people who need care. On the right-hand side is the proportion of patients who are admitted to UHP. This is in 2019, the latest data. And you'll see that for our 90-year-old population, 1 in 3 were admitted to UHP in 2019. And for our 85 to 90-year-olds, it was 1 in 4. So these people are coming to UHP, seeking help and being admitted. And this is reflected in the total bed days by age band. So we have a large number of neonates and newborns brought into being born in hospital and then attending hospital in early years. But you can absolutely see that as you get older, you're far more likely to spend your time in a hospital bed, and the average length of stay is very high. So what are we going to do with this information? Well, step one is trying to introduce it into our clinical strategy. So that's allowing the clinicians to think about how their populations are changing and using that information to drive change. It's working with primary care and the community, because we're not going to do all this work by ourselves. And it's quite clear that there are wider determinants of health that are leading to people seeking the care at UHP. There's acute integration in long-term care. So absolutely, we have specialties such as diabetes, but now going forward, frailty and aging, cardiology, respiratory and end-of-life care, trying to move their care out into the community to address problems in the community and avoid attendance at UHP. And that's quite clear on the graph on the right-hand side. In 2015-16, the diabetes team put significant effort into moving their care out into the community, and you can see there the blue line of GP referrals dropped significantly after 2015 and stayed down there. So GPs are able to use the expertise of the secondary care clinical team in the community to avoid patients coming in and being seen in our outpatient department. But that has to be paid for. So we're using this information to go to our commissioners and work with them so that we make sure that the right resources are allocated to us so that we can do what's right for the patient, even if that care isn't inside the walls of UHP. Alongside this, it's understanding that the healthcare services, the provision of healthcare, is only one determinant of the healthiness of our population. So it's working with others in Plymouth, broadly sitting under a banner called the Local Care Partnership, which includes ourselves, which includes the council, which includes Livewell, includes primary care, and it involves the voluntary sector, so that we understand our role in developing and delivering better healthcare systems. Basically, for this, a lot of our role is going to be signposting. It's going to be understanding better what services are out there in the community and how that the patients that attend here can be best signposted to the services which are going to support them best. And then as a final point, it's using data to understand and manage our waiting lists and our referrals in. So we're about to undertake a major piece of work looking at our waiting lists, which we know unfortunately have grown during COVID, and using that information to understand who's waiting on multiple waiting lists, what impacts that having on their health, and how we can try and empower them to wait well, potentially reprioritize people to ensure that they get to the right point on the right waiting list, have a broader idea of their clinical need, understand the health inequalities, and reduce cancellations and DNAs. Thank you very much for watching. These slides should be attached to the Friday 5 written piece, and I'm quite happy for people to get in touch with me in person to discuss this in more detail. Thank you.